Thank you once again for this opportunity. It is truly an honor to be able to do this work, and I'm very grateful for the Spore Evidence Alliance to provide us this resources funding to be able to do this work. Today, I'll be speaking about our project, which is titled Nothing About Us Without Us. It's the need for trauma-informed intersectional analysis of diabetes risk during COVID-19 through patient and public engagement. I'd like to acknowledge the land from which I'm able to do this work, which is a traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. So we're well aware that the COVID-19 pandemic has virtually impacted all aspects of our lives in the last almost 3 years now, and it has placed significant strain on our healthcare system, our economies, and the ways that we have been living our lives. This is a schemata that's mapping out the many ways that the pandemic will likely impact our health and well-being, especially in this third wave, where we're seeing that there's going to be, and we have seen this already, a delay or impact of interrupted care, particularly for chronic conditions. But also what we are seeing right now is this fourth wave, and we'll continue to see in the years to come, as many have speculated, is the impact of the pandemic on psychic trauma, mental illness, economic hardships in combination with other social distressors, burnout, onset of chronic conditions, as well as worsening of chronic conditions, and the adoption of unhealthy behaviors. And so in my previous work, I've been looking at the risk and burden of prediabetes and diabetes in Ontario residents, particularly among high-risk ethnic groups. But this research and my previous postdoctoral fellowship with Diabetes Action Canada, funded by Diabetes Action Canada, Dr. Gillian Booth and I were interested in looking at the impact of the pandemic on future risk of diabetes, specifically looking at healthcare utilization such as screening, prediabetes, and diabetes. And we have hypothesized that with the onset of the pandemic, lockdown measures, as well as economic hardships, food insecurity, and other inequities and barriers that have been experienced across various populations, we're going to see this impact on future risk and burden of diabetes that we may need to be thinking about and preparing for. And so in that first initiative, we first looked at the impact of the pandemic on diabetes screening and prediabetes and type 2 diabetes using population-based data sets. However, we know that the narrative is never complete without understanding how the pandemic may have impacted different populations in many different ways. And so we wanted to add an additional objective and explore more deeply in this research area to understand the lived experiences and the impact of the pandemic on diabetes risk, particularly among racialized and marginalized communities at risk of developing diabetes. And in doing so, our second aim along with that was to co-develop recommendations for potential research priorities, policies, and programs to reduce diabetes risk in these communities. And so, move on to the next, there we go. And so the reason why this is important is because in the context of Ontario, we have previously seen that prediabetes, which is a condition that precedes diabetes, this is where blood sugar levels that are higher than normal, but not high enough for a diagnosis of diabetes, has been particularly elevated in certain high-risk ethnic groups and has significant implications for future risk of diabetes. Now, this is data from pre-COVID-19, and we speculate that this burden is going to worsen in the future, in the years to come. However, why this research is necessary is because when we're thinking about diabetes risk and we're trying to reduce diabetes risk and prevent diabetes risk, we're often thinking about community-based solutions to this diabetes prevention that are rarely designed by the people in which they're intended to serve. And so there's been a call for research for some time now that is carried out with or by those with lived experiences. And in doing so, we wanted to understand the impact of the pandemic and lived experiences among those who are at risk of developing diabetes, and as I mentioned earlier, to co-develop recommendations for potential research and policy interventions, while recognizing the systemic barriers and inequities that may have exacerbated diabetes risk during the pandemic, and at the same time acknowledging past traumas. The idea that the ethos of nothing about us without us is not a new concept. It has been around for a while and has been operationalized in community engagement initiatives at the Taibu Community Health Center, who have been doing a lot of significant work on diabetes prevention and management, but initially was originated by James Charlton in the 1980s, where it was really to ignite a momentum and a movement to address disability oppression and empowerment. And now this has really just become a cornerstone when we're talking about patient and public engagement in health research, where we're trying to understand how can we actually do research with and by those. And so operationalizing this important message about what nothing about us without us in diabetes research. And so in doing this work, we wanted to know how did the pandemic impact diabetes risk? And in doing so, it was important to, there's an important need for patient and public voice to understand the lived experiences in order for us to inform future research and policy actions at various levels, at the micro, meso, macro level, whether it's the healthcare system or the community level. It's important for us to start to do active engagement at various levels in order to be better prepared in future public health crises. And so I'd like to acknowledge that this idea of trauma-informed intersectional analysis, I'd like to, Dr. Carolyn Shimon, the research that her colleagues have done in this work, these papers have been really integral in my own learning, in my own research and education, in trying to understand how can we actually, as researchers, recognize the importance of previous trauma and inequities and barriers that different patient and community members experience. And so just highlighting a few points from the work that Dr. Shimon has put forward, this idea of inclusion of patient and community members add great value and brings diverse perspective that would not have been actually recognized in this research without them. It also helps to recognize the barriers and inequities that often exclude patients and community members in health research. And so we know there are voices less heard of that among those who actually carry the greatest burden of illness. And so by applying an intersectional analysis, it allows us to really dig deeply into the inequities that lie deep within and across systems and societies as a whole. But also as researchers, it's really about recognizing our own positions and power and what we bring to the table and what positions and places we hold. So practicing a lot of critical reflexivity and embodied reflexivity. And so I'll walk you through our research really quickly now. We got funded, thankfully, in April 2022, and I'll just walk you through the project that we have embarked upon since then. We went through several rounds of REB approval. We're very grateful to the REB team at Unity Health Toronto St. Michael's Hospital, a fantastic team of experts who were really helpful in helping us reach get our ethics approval. Right after that, we've started recruiting a project advisory committee as well as our patient and community partners. So we had two engagement steps. The first one was to establish a project advisory committee that would be comprised of community health leaders from community health centers and organizations to guide various steps of the project. And then recruit our co-researchers, which we refer to as our patient partners via Diabetes Action Canada and our community members via the community health centers. So these are the community health centers and organizations that we were able to bring on board: Women's Health in Women's Hands, Flemington Community Health Center, Black Creek, Taboo, and Alliance for Healthier Communities with Dr. Jennifer Rayner, who really has been a champion in helping us forge alliances with these CHCs. Our project advisory committee members had several roles. First, I was to meet to discuss the project overall. We had a project launch in August, or discuss our recruitment plan and how they would be helping us in facilitating the recruitment of community members. They're actively involved in providing input in terms of the several aspects of the project, such as the focus group discussions and along with recruitment, but also how to strengthen the various aspects of the project. They're also invited to provide written feedback to our reports and manuscripts that will be coming up from this project, as well as to the opportunity to serve as co-authors, and any appropriate referrals to other community health leaders who would be interested in serving on this committee. So in terms of bringing on board our community, our co-researchers would be our patient partners and our community members. So we are, as I mentioned earlier, we've been bringing on board patient partners. We have actually, so this has happened. I'm speaking of it as the future tense, but we've actually done this already, and as well as bringing on board community members. So we had these two-step processes to bring on board patient partners as well as community members. This is an example of the poster that we sent around to the CHCs. They posted it around at the front desk reception area. We also shared it with Fazli via email to share with potential clients who would be interacting with the CHCs, as well as with Diabetes Action Canada as well. So once recruitment was completed in October, we had our first focus group meeting in November. But I'll walk you through our specific focus groups and what they are, what the priority would be for each session. We have planned for 4 focus group sessions. The first one would be to understand the impact of the pandemic in terms of barriers and inequities and opportunities for diabetes risk. The second would be to use concept mapping to exercise and sort rank in these barriers and inequities experienced during the pandemic. The third focus group session would be to synthesize the data and co-create knowledge to identify research priorities and methods and policies or programmatic interventions for diabetes risk reduction. And finally, to identify dissemination strategies and engagement with different stakeholders in order to translate this research into future research policy programmatic opportunities. Our 4 focus groups are about 1.5 to 2 hours long. They're held virtually. Our participants are co-researchers. I know we refer to them as in different ways. They are individuals with lived expertise. Our compensation follows the Diabetes Action Canada compensation with $25 per hour for each focus group session, as well as a one-time coffee card. These focus group sessions are meant to end in March 2023, and we have already scheduled our second one for January 2023. So this research really is an example of community-based participatory action research because it focuses on the process of reflection and action. And this involves community members. The work is carried out with and by community members rather than on them. And the community-based participatory action research in this project at its heart is an iterative process of collaboration, conversation, empowerment, reflection, and action. But also the importance here is that researchers and our research team, as well as our community members and patient partners, are equal partners. And we believe this is the way that we can actually operationalize and move forward by co-developing those research and policy program suggestions and ideas for future diabetes prevention strategies. And so we're using a concept mapping approach where it involves 4 stages. This approach is essentially starting off with brainstorming session, which is what we had in November with our participants. Our future meetings are going to involve sorting and rating the ideas that are generated from the brainstorming session. and then an analytical step, which would involve creating different visual maps to show where those priorities and actions will fall. This is an example of concept mapping that I use often with my students, where, if you just want to think about just starting off with brainstorming about what influence our health and well-being, and it's essentially how our first session went, where we asked questions about impact of COVID-19, and our participants were able to really map out in so many ways about how we can think about the impact of COVID-19 in relation to diabetes risk reduction. Really, you start at the center of a question, and then it branches really out into many areas until you feel that as a group you've reached saturation. So in this brainstorming session, we asked our participants to highlight at least 2 areas prior to coming to the session, at least 2 areas that they would like to discuss with us at this meeting. Not everyone would be able to talk about every single item on this list, but just to give you an idea, we kept it quite open and broad to get an understanding of what our participants would say about the different impacts of the pandemic. And actually, we were able to hit on all these areas, and we did reach saturation by the end of the 2 hours. And so this was the meeting that we had in November, on November 24th. We actually had 20 participants join, and we're still getting interest to join in the study, although we've reached our capacity for participants. We had a great number of patient partners, as well as community members who were able to join us. Our data is currently going to be transcribed by To the Letter Transcription Services, and our next steps would be to review, summarize, and synthesize the data from that first session to prepare for our second focus group that will be scheduled at the end of January. We also offered our participants other ways that they can contribute to this work. Our discussion was very rich, and everyone was very enthusiastic and excited to continue the conversation. We actually had to force to end the meeting at the 2-hour cap, but we've asked them if they would like to be involved in this research. Further, they can join our meetings when we have analysis and interpretation meetings of the data, our presentations to other stakeholders in the future. Also the opportunity to potentially participate in the presentations once we have our data from this work, and the opportunity to participate as co-authors in reports and manuscripts as well. So this is where our next meeting will be, and this is where we are in our project. I will end by just saying that the Spore Evidence Alliance is really, it's a seed grant, but I think of it as a seed grant. It's going to really ignite a lot of engagement, conversation, and momentum in this area. So never underestimate the power of a seed grant funding. A lot of our community advisors and many stakeholders that we've met have said to us, this is a seed grant because this is a very ambitious and massive project, but I can't say how grateful I am and our team is for this opportunity because of the amount of interest and just so much synergy and momentum that's really coming our way in doing this work. And I'd like to thank my postdoc supervisor, Dr. Jillian Booth, and our collaborators, our research team, our project advisory committee, our focus group facilitator, Chantal Curry from Women's Health and Women's Hands, our patient partner liaison and collaborator, Lindsay McNally from Diabetes Action Canada, our patient partners and community members, as well as I mentioned, the funding sources that have allowed this work to happen. Thank you.
Great. Thank you so much, Dr. Fazli, for a really informative presentation. So while we give everyone a minute or two to think of some questions, and just to remind people that you can either type your question in the chat, and I'm going to be moderating that, or you can raise your hand and take yourself off mute and ask your questions. So while you're thinking of a great question, oh, actually, we have a question right away. We have a couple questions. Okay, so why don't we start off with Heather? Heather Hong?
Hi, good morning.
Hello.
Thank you everyone for allowing me to join. I think the presentation was fantastic. My question to the presenter was, in terms of the participation, I think you mentioned there were about 20 individuals joining the focus groups. Can you tell me the age range?
Oh, that's a great question. So we're looking for adults We did not ask for a specific age range of our participants.
Okay. So in terms of the general feel when you saw them, I'm hoping that in Zoom, the Zoom conversation was face-to-face, but did it look like there was a majority younger adults, middle-aged adults, or elderly adults?
I think I would be a little biased to say, but some participants did not come on Zoom video in the consent process. And when we had back and forth with REB, that was actually something that we had quite really just hash out. And so in the consent form, we did tell participants that they do not have to be on Zoom video, and a few people did not want to be on video. In terms of, if I could give a guess, I would say middle-aged adults would be the guesstimate.
Okay.
But we did not ask for that data. Yeah.
Okay, great. Because it's actually very interesting to note. I'm doing a similar kind of approach, but there seems to be a tendency for the more elderly adults to not really want to participate in, especially technology advanced group meetings, right? So there might just be a bias towards, if you did want to take that up, to see what age group your participants are falling in.
Yeah, that's a great suggestion. I can look into that.
Thank you. Bye-bye.
Great. Thank you so much, Heather. That was a great question. I think we will move to Rosman Ismail next, please.
Hi, thanks, Ghazal. That was an excellent presentation. I'm Rosman, and I'm the Assistant Scientific Director with the Diabetes, Obesity, and Nutrition Strategic Clinical Network here in Alberta. So my question was kind of similar to Heather's around the demographic profile of the focus group. And I was wondering, what about the different ethnic cultures that were represented? If you could tell us a little bit more about that. And then I had a second question, if I can ask, is the focus group for 2 and 3 and 4, would it be the same participants as focus group 1, or do you have different participants for those focus groups?
Thank you. Pleasure to meet you. Those are great questions. So I'll answer the second one first, because I think I'll have a longer answer for the first one. The focus groups will build on each other. So it will be the same participants. We have had some interest from participants who wanted to send their feedback, and I've looked into it, and I've talked to other colleagues who've used similar methodologies, and technically you can have participants who can come in at the next focus group sessions, but there's going to be a core group that's going to continue to be involved and throughout all focus group sessions. The first question, so we do have an ethnically mixed group of participants, and the reason why that is the case is because of where we are drawing our community members. Black Creek Community Health Center predominantly serves Black clients, Black community. Then Flemington Community Health Center, we noticed that they're running a tailored South Asian diabetes prevention program. So we have some South Asian participants. We also have participants from Southeast Asian, and women's health and women's health is quite broad as well, predominantly serving marginalized and racialized communities. And so when we were reaching out to different community health centers, when we were kind of interviewing them and getting an idea of their projects, we wanted to know who were the types of community members, clients that they were often interacting with, and it was predominantly racialized and marginalized community members. So we do have a mixed group of participants, and what's interesting is that some of them have already been involved in diabetes management and COVID-19 projects and so on. So they were able to pick up really quickly, and were able to respond to our questions, and we didn't have any challenges in the meeting.
So I'm assuming the focus groups were in English. And so do you think that there might be a bias towards people that are English speaking versus those that aren't, that participate in your focus groups? Sorry, I'm asking too many questions.
No,
this
that's
is
a
my
great
last
question. That's a great question. And so it was in English, and there definitely, it does introduce a bias, particularly because we didn't have a French, we didn't run the session in French. We wanted to bring on board a facilitator, which I didn't mention in my presentation, from the community, who actually works in diabetes initiatives, who's attached but not really attached to research. So Chantal Curry works in women's health and women's hands and has been doing a lot of facilitation, but to go around, we didn't have the capacity to bring on board a French facilitator for this project, but it is a feedback that we have received, and we hope to be able to do that in future work for sure.
Great, thank you so much for those great questions. We have one last question in the chat here from Naila Kulman, and please correct me if I'm pronouncing that incorrectly. And so basically Naila is asking, thank you for the great presentation and for the thorough outline of your process. I'm curious if you could elaborate on some of the challenges you had for REB approval. Was it more difficult or longer due to the participatory nature of your research? And this will be the last question.
That's a great question. Thank you. The reason why our REB was, when we submitted our application for REB, we essentially, the individual helped us work through developing a lot of documents that we needed to have for this project. For example, our consent form, our invitation letters. We had a lot of elements involved in this project. So as you can imagine, the recruitment of project advisory community members, and then the recruitment of participants, working with the advisory members, working with Diabetes Action Canada. It was, even they said this is a massive, it's like a research grant project, but it was a seed grant. So that's the nature of the amount of work that was involved, helped us really hash through every aspect of the project, which I highly recommend to really think through the entire project from beginning to end in every aspect, and have REB review every letter, every invitation, because once you have that ready to go, your project is basically ready to roll, which is when we got the approval, we were able to just go forward and we had no delays whatsoever because all our material was pretty much prepared and approved. And then there's administrative institutional policies for, if you have a poster, it has to be approved across various levels. So there's some delays that are institutional, but really it helped to strengthen the way that we were going to roll out our project.